Good morning. Well, I'm going to talk about the same sort of concepts down on the lower end of the tibia. I don't have any disclosures relative to this particular topic. So I always focus better when I've got a case I've got to make a decision on kind of in front of me. So I'll just present this guy to you. This guy does this for a living. He's upside down and not holding on purpose. He is prone to trauma, as you might imagine, and one of his crashes, he sustained this distal tibial fracture. You see it involves the distal diaphysis and has some extension down into the joint. There's a CT scan cut in his tibial plafond. And if you notice, he's got ACL interference screws from some prior injury there in the past. So just think about how you might treat this while I go over some of these concepts. So in this particular patient, why would you consider a nail? Okay, well, this guy is a professional athlete. He wants to get back on a snowmobile tomorrow, maybe even today. He's prone to accidents. He will not stop doing what he's doing. With a nail, there's no subcutaneous hardware except for the interlocking screw heads, hopefully not the upper end of the nail. You can potentially allow earlier weight bearing with a load sharing device and return to work and sport, which for him are the same thing. He does have a limited articular injury that can probably be managed with screws alone and doesn't really need a plate. And then a nail is perfect for the diaphyseal component. And as we just saw, the semi-extended techniques make this easy. It used to be when we nailed the tibia, we did it in hyperflexion and you were constantly having to move the leg around to get your imaging. But with the leg just laying there in extension, it really facilitates both getting and obtaining fracture reduction and then inserting the nail. So we'll talk a little bit about that. But what about a plate in this patient? I mean, this guy really depends on his knees. He's sort of kneeling and squatting all the time. He's got to absorb all that shock with his knees. He's had prior knee surgery. And we know that up to 40% of patients have some knee pain after a nail. So that may be a reason to avoid a nail. Plating it can be quite easy, especially in a fracture that's not that badly displaced. Maybe it's faster. It certainly can be minimally invasive with these new MIPO techniques that we just heard about. But there's a soft tissue concern, and at the beginning of Don's talk, he showed a case of all those fracture blisters. We sometimes see those in these distal tibia fractures. A minimally invasive plating does certainly have a high fiddle factor, and if you're not really comfortable with that and how to do that sort of minimally invasive plating, it can be a problem. The plate itself is going to be more prominent since it lies on the outer border of the tibia. If it's on the medial side, it'll be subcutaneous. If it's anterolateral, there's still potential issues with plate prominence. And then in this patient in particular, there's that issue of potential stress riser at the top of the plate and potentially a site for another injury down the road. So as Don said, the literature is really very poor. It's mostly case series. Here's an example from the Seattle group. Very good surgeons. They had 36 of these distal tibial fractures. They were, to be in this series, they had to be within 2 inches of the knee joint. For some reason, they excluded patients with blockage screws. I'm not sure why. And these were adults. They did allow or include simple intra-articular fracture patterns, such as we just saw. And they also excluded patients with axial loading, so the P-line sort of fractures, and this was all the surgeons that were practicing at Harborview. So they had a series that was 2/3 male with a typical mechanism of injuries you'd expect in young men. Just over 1/3 of them were open injuries, and the same proportion were polytrauma patients. 1 out of 6 patients had an external fixator, presumably because they were either polytrauma and or a severe soft tissue injury, so some of them were staged. About 2/3 of the patients were these extra articular fractures. About 1/3 of the patients had these more simple, typically intra-articular fractures. But you can see they did do a couple cases that were indicated as type C3 fractures, so there was even articular comminution. All the type C fractures had a CT scan and some supplemental percutaneous fixation, which I'll show an example of. The post-op course, though, they did limit the weight bearing in the type C fractures to 12 weeks. The type A fractures, they allowed weight bearing after 6 weeks. All the patients were allowed free motion of their ankle unless they were, quote, unreliable. And you could argue about my patient, whether he might be reliable or not. But they had good results. All the patients had acceptable alignment, typically within a degree of, or less than a degree of deformity. There was no loss of reduction with time. Some of the open fractures had to be bone grafted. They had to dynamize some of the nails, but all of the fractures healed, and there were very few complications. So basically, they concluded that nailing is a safe and effective technique. It's important to follow the principles that we just heard about. Again, obtain accurate alignment prior to proceeding with nailing. So in more than half their patients, they plated the fibula. Sometimes they used unicortical plating. The indication for that was essentially an open fracture where the patient already gave you the exposure. Percutaneous clamps and distractors were used, and they used 2 to 3 distal interlocking screws. This is another paper. This is a review paper that was published in Journal of Orthopedic Trauma, a literature review around the same period of time, up through the mid-2000. They found 15 case series in one retrospective study, and they had nearly 500 patients with nails and just over 100 patients with plates. They really found very few differences overall. There tends to be benefits of the nails in this review. Of plates. Surprisingly, the plates had half the infection rate of the nails, 2.6 compared to 4.3%. There were slightly fewer malunions in the plates and fewer secondary procedures in the plates. So maybe a trend towards a little better results in the plating group. But the bottom line was that there's not a significant difference and that more research is needed and ideally some prospective trials. Now, there is one such trial that was published after this. This was a single surgeon study, nearly 80 fractures, and he randomized by drawing from a box, which is not ideal, but one method of randomization excluded the high-grade open fractures, and these are the demographics. Fairly similar, although far more fibular fractures in the nailing group, which makes you wonder a little bit whether there was some selection bias despite the randomization. But anyway, the results, again, were similar, but in this study, slightly in favor of the nails. So the nails had a little shorter OR time. I don't know how you measure it down to that minutes, 70 minutes versus 90 minutes. Union, again, 2 weeks. I'm not sure how you measure union with that degree of precision. Complications were fewer, and ankle dorsiflexion was better. So the literature, so he concluded improved ankle motion, decreased soft tissue complications, and although I didn't show it in the results slide, improved alignment with the plates. So I think if you go through the literature, both are perfectly appropriate methods to treat these fractures. The soft tissue injury often dictates management because plating is dangerous in that circumstance, and I'll hit that point a few more times. And then you also have to consider the issue about knee pain or patients that need to kneel, which might steer you towards a plate. So now we'll spend the rest of the talk going over some technical pearls and how to deal with some of these challenges. So when we're talking about extreme fractures, end fractures, whether you're talking about the proximal or distally, you have to have some other means to control the reduction. In a midshaft fracture, sure, the nail will straighten the bone out as you insert it, but in a metaphyseal fracture, the nail will just fix it in situ. So you have to have that reduced and to be able to control it during nail insertion. The cortices are wide and thin and don't really contribute very much. Sometimes the soft tissue attachments to form the fracture. That's a big problem in the proximal tibia, maybe less so distally. And the process of nailing can, especially in the proximal fractures we just heard about, and having to flex the knee can deform the fracture. And again, some of these newer techniques mitigate that. And again, if you have articular involvement, you have to have a plan for how you're going to manage that. So one of the common mistakes, I think, with metaphyseal nailing in general is to forget that the nail will not reduce the fracture. So again, you have to have a way to reduce it. So you want to reduce the fracture. That's point number one, and you heard that in the previous talk as well. And not only do you have to reduce the fracture, but you have to be able to maintain it during the entire nailing process. So that can be a challenge sometimes. We tend to use reamed nails now, so again, you need to ream the fracture with a reduction maintained. So that means whatever method you're using can't block the medullary canal. You want to be able to place the nail across the reduced fracture and then insert your interlocking screws, again, with the reduction maintained. And although this is simple in principle, it's not always easy in practice. So there are a lot of tricks that you can use, the same exact ones we just heard about. Applying an external fixator or a distractor to help hold the fragments in place can be very helpful. And you can put a fixation pin in the posterior tibia to help maintain length and alignment if that's your choice. Percutaneous clamps work beautifully because the tibia is a percutaneous bone. Unicortical plates are a good option. I'll show a good case of that. Blocking screws can help, just as we've seen, and then fixing the fibula is another component that can help you, but it can also harm you if you malreduce the fibula, so you have to keep that in mind as well. And fibular fixation is, I think, easiest or best in the fractures that you know you can reduce anatomically. So here's an example of a fairly simple fracture. This is maybe not quite as close to the ankle might be nice to show for an example, but this is still a fairly distal fracture. The issue here, though, as you see when you get it out to length, is there's some bone loss. So there's a comparison view of the other leg. And when this fracture is reduced, you can see that big butterfly piece is gone. So this is one way to stabilize the fibula. This is nearly essentially a transverse fibular fracture. So this is a long screw that's inserted as a retrograde nail, if you will, on the fibula, and that's going to help maintain length and control a lot of the translation and alignment of the tibia. This is an open wound, so again, a unicortical plate can be readily applied, and you see that in the lower left, this small plate maintaining the fracture. This really highlights the bone gap that you have now, but then you can go ahead and insert your guide wire, and then finally the nail. And of course, a case like this is going to require a bone grafting at some time. So here's another case very similar to our snowmobiler with articular involvement, very similar sort of fracture. That can be reduced with clamps and fixed with percutaneous screws. And then this shows the nail after it's inserted and interlocked with 3 screws. And most of our tibial nails have 4 interlocking screws now. So most of our tibial nails work fine. Most of them have that distal screw very close to the tip of the nail. And here's another follow-up of that case. This is a nice technique article that was in JBJS talking about the semi-extended technique that Don talked a little bit about. So you can perform the entire procedure with the leg in this position. You can move the C-arm to get your AP and lateral images, and it really facilitates nailing, whether it's proximal or distal. So this is a wonderful case that Dave Bray put in our textbook, and this shows a mid-shaft tibia fracture going all the way down into the ankle joint. So again, step 1 is to plate the fibula. Step 2, percutaneous reduction of the plafond. Step 3, percutaneous clamp fixation of the tibial shaft. And then lastly, the suprapatellar portal for nailing that allows you to fix the fracture without moving the limb. And here's his final construct. For plating, typically for the MIPO techniques, it's a medial-sided plate inserted through small skin incisions and percutaneous screw fixation. This is sort of an example of how not to do plating. You can see the plate's not even really on the bone. It's not aligned in the lateral view. You can use these anterolateral plates as well, which are nice because they tuck the plate under the anterior compartment and it's a little less prominent. Preliminary external fixation, small and distal incisions, stab wounds for the screw holes. You have to rely on imaging. And just like we talked about yesterday, you don't need a lot of screws in these cases. 2 to 3 screws on either side is good as long as they're kind of near and far and you have a long plate. Stiffness can be an issue, just like we talked about with the distal femur. And so the far, and near construct for screw placement is a good rule of thumb. Here's an example again of a spiral fracture in the distal tibia. A MIPO type of a plate. Another case, a more transverse fracture with follow-up. So in conclusion, nails and plates can be used to treat fractures. You really have to consider the patient and the injury, and probably most importantly, the soft tissue envelope. If you're going to use a nail, you need at least 2 and more typically 3 or 4 distal interlocking screws. To really understand and define the benefits of these approaches, we certainly need better research. So this is our snowmobiler, just to show what we did. So here's a tibial nailing. If you look carefully, you'll see that we did not use a suprapatellar portal. In this particular case, I think I was really worried about going in his knee again, and we were able to reduce the fracture and hold it fairly easily. So we did a standard sort of infrapatellar approach, but we got beautiful alignment, as you can see, and he's still back competing professionally. So this may be the most important slide, though, is when you're thinking about these techniques, you've got to consider the soft tissues and whether they'll be amenable to plating. Definitely do not plate if the soft tissues are tenuous, and these new techniques of nailing are very safe and very effective for these end fractures. Thank you.